once again, to one of our biggest platform which we have created in India called TransTech Connect, which is basically a platform where the tech physiologist comes together and tries to discuss on various aspects of complex, and we do have a lot of conversations on a complex cases. And this has been a very great opportunity. And this program of TransTech Connect has a very special edition today, which has been jointly brought together by Shockwave Medical Corporation US and TransLumina together. And it's a great privilege. I take this opportunity. My name is Ehsan Raza. I work as the General Manager of Marketing at TransLumina. Take this opportunity to welcome you all for taking out time for attending this meeting. But before we get into this discussion, I thought of trying to take an opportunity to discuss and have a sneak peek view on what does basically TransLumina as a company stands for. It's a humble beginning about a decade, where today we have great facilities in Germany and India, and with our great collaborations with our scientific aspect on German Heart Center. Most of our products are very C certified. But what is very important to us and very dear to our heart is basically our close collaboration in working and creating strategic partnership with one of the finest companies of the world, especially with Shockwave US, with this company, with basically Abiomed and Kanika's, Asahis of this world, and tries to get a best product so that making innovations affordable has been our key concern, and trying to see that how do we make treatment outcome better. And very proud to share with you, we are the only company in the world today to have a DS technology with polymer free and a polymer stent. And both of them are very well studied over a period of 10 years, which perhaps no other company in the world can have this as a landmark. This we are very proud of and would like to see that you can use it for more and more patients. Having said that, let me have a great privilege and honor to have the speaker of the evening and welcome and introduce Mr. Mark Sheehan. He is a medical education and a professional relationship manager at Shockwave Medical. He has been someone, he's just 8 weeks in the world, but don't go by his 8 weeks being in the Shockwave, but he brings more than a decade experience of being in this field of medical technology and medical devices, and he brings a great understanding on the table. He is someone who started as a cardiac technician at St. James Hospital with experience in one of the finest organizations like Abbott, and as a scientific company as a country manager and regional head. He has been so well accomplished that he was awarded the President's Club Award at Boston Scientific, and he has a myriads and vistas of experiences bringing in. He has worked in Europe, Middle East, and African countries, and he has been awarded as a salesperson amongst all those countries in the year 2020 and 2012. That has been his feat of achievements in the field of his professional career and journey. That's what has been achievement. And apart from that, I have a great honor today to introduce to the esteemed expert panel. I think these are some of the pearls of the basically technical physiologist concerned in this country. Let me have the privilege to start the introduction right from left to right. Mr. Arnab Dey, who is at Medica Super Speciality Hospital, Kolkata. Mr. Andrews, who everybody know, Apollo Hospital, Chennai. Mr. Avtar Singh at Fortis Hospital, Mohali. And then Mr. Anand Trivedi from ESCC, Jaipur. Mr. Anand Rawat, Max Hospital, Patparganj. And Mr. V. Venugopal from Sunshine Hospital, Hyderabad. Mrs. India Sokan from KIMS Hospital, Trivandrum. Mr. Sudhir Shetty, I would say Professor Sudhir Shetty from Jaslok Hospital, Mumbai. And I know Mr. Samuel, Dr. Samuel Sakaria from Apollo Hospital, Bangalore, and Mr. Santosh Dubey at Medanta Medicity, Gurgaon. I think these are very cherry-picked people and who would be contributing to make this program a very successful one. I know now you all of knows the agenda. 8:05 to 8:10 was basically the introduction. Now I hand over this topic to Mr. Mark Sheehan, who's the speaker of the evening, to talk for next 30 to 35 minutes, where he's going to talk about real troubleshooting tips and tricks, that will be followed by a panel discussions and question and answer from all participants. For participants, once the topic of Mr. Mark Sheehan ends up and we have a round of panel discussion, then we will open up for question and answer session, Q&A session. What you can do, my earnest request to all of you, your contribution would be so much valuable. Just raise the icon of hand and we will open up for you, because if you open up for all, you understand there will be more of a chaos and then the discussion will not have a very fruitful outcome. Hence a very earnest request to all of you that just raise hands through the icon and we will open up, and you can, a question and answer can happen, and in the meantime you can have a brief understanding and discussions as you like. So over to Mark for his wonderful presentations. So over to you, Mark. It's all yours.
Thank you very much for that very warm welcome. It's been a long time since I looked back at my CV in that way to look at what I have achieved over my career. But as a way of introduction, I will, so as you said, I started life as a cardiac physiologist, much like most of the audience on the call today. I started work in St. James's Hospital in Dublin, which is the largest cardiovascular centre in Ireland. And I've worked in Australia as well as the UK as a cardiac physiologist. I joined industry with Boston Scientific as their clinical specialist for CRM and EP 15 years ago. I spent 10 years with Boston Scientific across EP, CRM, and in their vascular space as well, before then joining Abbott Vascular 5 years ago to lead their OCT and FFR clinical development and commercial development here in Ireland as well. So I've been asked, I joined Shockwave then 7 weeks ago as their medical education manager. So as I said to the panel earlier on, this is hopefully going to be a learning experience for me as it is for you guys, because I know from experience that when cardiac physiologists come over to work in Irish hospitals, they are very well educated and really well experienced. So I'm very much looking forward to this session. So thank you again for the invite. So I thought I'd start with just a very brief, and forgive me if this is too basic for everybody, but I think it's always good to get back to basics at the start of any presentation and understand why we're going to talk about the topic we're talking about. In that, what is calcified coronary lesions and why is it that they're an unmet clinical need for us? So I always like to, I've been lucky enough to been to cadaver labs recently with Shockwave. And it was a real eye-opener to me to get hands-on experience of feeling heavily calcified lesions and feeling the compliance change and difference between a normal, healthy artery and a heavily calcified artery. And the expression of lead pipe as a description is very accurate. When you get hands-on on a heavily calcified lesion, you can really feel the compliance shift from a healthy flexible vessel to a rigid lead pipe like vessel. And what does that mean when it comes to treating these lesions and treating FFR positive lesions? That flow limiting lesions means that it's very difficult for the physicians to get their kit across these lesions, because the flexibility and compliance within the artery is no longer there. So either stents come off the balloons, or if they do manage to get a stent implanted, the MLA of the stent, or the minimum lumen area, is not wide enough to treat the patient's symptoms. And hence from this study, we can see that underdeployed stents are associated with an increased risk in ischemic events, which makes perfect sense, right? That the idea that we're putting a stent in is to increase the lumen area within the artery, because the undersized artery is the thing that is causing the patient's adverse events and ischemia. And if we implant a stent that's undersized or that has calcific lesions around it, then we're not going to improve our patient's symptoms. So what are the limitations of the conventional calcium tools, albeit Shockwave is relatively new to the Indian market and to the European market as well? I think the first port of call that physicians tend to use are high pressure balloons, which in themselves, in their design, can cause some dissection and perforations when they come across that immovable object, which is calcium and very thick layers of calcium. Looking at rotablation, which has been widely used for many, many years as an area of treating calcium, just two things that from my perspective stand out to me when I was supporting rota cases is that the size of the burr is directly dependent on the outcome. The larger lumens, they have to be in contact. So that's something for left main disease and large osteal rights that we always need to keep in mind. And the unprotected secondary side branch is also a big concern when we're doing rota. So if we look now within IVL, I think everybody has heard the story of where IVL originated in terms of looking at the treatment of kidney stones and turning that technology into a balloon-based technology with the emitters on the balloon to be able to go into the coronary arteries and to the lower leg region of the body to be able to break up and modify calcium. So everybody will be very familiar with the kit for Shockwave. You have the generator and the connector cable, which are obviously reusable and not to be disposed after the case. And then obviously the single-use catheter, which for coronary is the C2 catheter, comes in sizes 2.5, 3.0, 3.5, and 4.0. The working length of the balloon is always 12 millimeters. And in terms of area. So this would be ideal if this was real life animation that we see here, that the idea of what we're trying to do of modify the calcium. So compared to if we look at rotablation of what some of the advantages of IVL from both from a physician standpoint and also from our standpoint as physiologists and support within the lab, it is much, much easier to set up. From our standpoint, it is much easier for the physician from going from zero to having calcium modification within their lab. You also able to protect side branches with the additional wire, which is a big, big advantage. And in terms then, if you're looking at left main disease or larger lumen areas, contact with the treatment area of the calcium is obviously much easier with IVL. I am going to quickly share this video and let me know if you can't hear it, please. Can you hear that? Is that video playing okay?
It's playing, Mark, but we cannot hear the volume because perhaps it needs to, you need to select the sound.
Okay. There you go.
The lesion using marker bands under angiography.
Yeah, it's coming now.
The 1-to-1 sized balloon expanded to subnominal pressure of 4 atmospheres. The 50-50 saline contrast mix within the fully enclosed balloon acts as a coupler to facilitate efficient energy transfer into the vessel wall. The generator produces electrical impulses that travel to the lithotripsy emitters once per second, where they are converted to acoustic pressure waves that pass safely through soft tissue without thermal injury.
Okay, that's frozen. Apologies.
Fracturing both superficial and deep calcium. When the waves impact the calcium across the 12-millimeter treatment zone at the equivalent of 50 atmospheres, they create a series of microfractures that increase vessel compliance and achieve excellent lumen gains consistently across concentric, eccentric, and nodular calcium. This allows for circumferential stent expansion with a large minimum stent area. In a standard interventional
Okay, so I think that the key points of that video are what I had spoken about earlier in my presentation, in terms of you're looking for your stent area to expand and modify the calcium before we do that. The other really important part of that is the 4 atmospheres for the balloon. The balloon atmospheric pressure is not what's modifying the calcium. It is the IVL technology itself that is doing that.
The emitters fire electrical impulses across electrodes, which result in a plasma discharge, creating a vapor bubble that rapidly expands spherically, creating the initial shock wave. When the vapor bubble collapses, secondary smaller shock waves are created. The shock waves travel deeply and safely through soft arterial tissue because of the similar acoustic impedance of water and soft tissue. Fractures occur when the shock wave encounters tissue with differing impedances, such as the transition to superficial and deep calcium. The leading edge of the shock wave imparts compressive stress as it encounters calcium. Shearing occurs as it passes through the calcium. At the rear edge of the calcium, the shock wave is both transmitted and reflected, inducing tensile stress that pulls the calcium apart. Squeezing occurs when the shock waves entering the calcium travel faster than the remaining wave propagating outside the calcium. These forces result in multiplane and longitudinal fractures.
So I think my take-home message from this video and slide is really to understanding what is modifying the calcium and the safety within that modification of the shock waves and the sound waves that are traveling. Because again, in my experience, when I was with Abbott and supporting OCT cases, and now with Shockwave, is the varying, how do I say it, the treatment strategy that physicians apply with Shockwave, in that they have, out of the 80 pulses, they could deliver 60, they could deliver 50, and deliver it in different areas. That it's important as support members within the Cath lab for us to understand what is the treatment strategy of physicians. And like we all know, it may vary from physician to physician, but from our standpoint, it's important to understand their thought process around, when it comes to Shockwave, how they plan to treat the calcium. So again, this is just a very, very quick short video looking under a microscope, really, to see how the bubbles travel. And you can see when the emitter fires off, the shock bubble is emitted and the sonic pressure causes that waveform to then travel through. And I'm sure everybody has seen these videos as well, but it's a really good illustration to highlight the safety of IVL when it comes to soft tissue. And again, discussions with physicians can sometimes be difficult, but in terms of the understanding of what exactly IVL is treating versus the safety of what it is passing through safely, it will only modify the calcium that you are trying to target and not the soft tissue that is around it. And I can vouch for this. I've done this. I'm sure when the team brings Shockwave to your labs, they'll be able to demonstrate that to you as well. And some of the key differences on the mechanism of action of traditional angioplasty versus IVL is that balloon only is always a compressive force, where IVL has a combination of compressive, shear, and tensile stress, which causes that fraction, and then that negates that compliance change that we're looking for in IVL. We can also look at the mechanism of action under OCT and look in multiplane and longitudinal calcium fractures to show that we have successfully modified the calcium enough to then place our stent. And ideally, this again is best practice, that you would image before to confirm calcium, to confirm the arc of calcium and the thickness of calcium, obviously the length, and what the ideal minimum lumen area that you're looking to achieve post modification. And then obviously post modification, a second run of whether that's OCT or IVUS to confirm that the calcium has been modified enough to get the stent down. Too many times we see calcium modification techniques not supported by imaging and whether they're unsuccessful or they're not fully 100% complete, that a stent is placed again, and it's too early within the procedure to place the stent, and it's not an optimal outcome. I'm sure everybody has seen OCT in their lab, or for the most part, imaging, whether it's IVUS or OCT, to see those fractures. Now, beyond that, you don't always see fractures on intravascular imaging, but the clinical studies that Shockwave have completed are done beyond IVUS and OCT, and they're looked under micro CT to confirm that the fractures are both superficial as well. Again, this is just another slide to show that. So ultimately, I guess that was a short, brief overview of why we use IVL and why we use IVL versus the other technology out there. I really have been asked about the troubleshooting, which I spoke to Boraj before my presentation, say, 35 minutes on a troubleshooting and tips and tricks is really not possible. The design of the catheter and design of the system was to be as troubleless and to have very little troubleshooting as possible. So quickly, we look at the C2 catheter that we have. When we come to sizing, it is important to have 1-to-1 versus the reference vessel diameter. And that always becomes I guess a tricky question to answer if we're talking about a longer diffuse disease within a right coronary or left coronary artery, where you have a 2.0 vessel distally and it goes up to a 3.5/4.0 on the proximal reference side. So that's always a difficult one and a tough discussion with physicians of using 1 or 2 balloons. Ultimately, we are looking for that 1-to-1 reference. So depending on the length and the size difference from proximal to distal, it may need 2 Shockwave balloons to treat that. And also very important to understand that going over 4 atmospheres does not improve outcomes when it comes to IVL. You don't improve the amount of delivery of energy you get over 4 atmospheres. And this was all proved during the bench testing plus the clinical studies that were done afterwards. And hence 4 atmospheres is our optimal pressure, up to 6 atmospheres post your pulses delivered and then back down again. So if you take anything away from this presentation, I think it is preparation is key to avoiding any troubleshooting events. The more time you can get your cath lab team, whether it's the physician or a scrub nurse, to prepare the balloon and purge the air, the less issues and troubleshooting you will have further down the line. The 1-to-1 saline contrast mix, and it needs to be purged 2 to 3 times with a 10 or 20 ml syringe. This, in my short time with Shockwave, has really been driven home to me as to anybody who wants to avoid having to troubleshoot the catheter. This is absolutely critical. So not only for the error messages, but also for the outcome, that this is critically important. So air within the catheter may also give you an error message, but it also will have an issue with the energy that we're transmitting from the emitters into our target calcium, in that it won't be as effective. So on to what we look at when if we're in the lab, and as physiologists, everybody will turn to us and say the catheter is broken or that the generator is broken, and we will get up to 4 yellow amber lights as error codes from 80, 81, 87, and error 88. And we may from time to time see the error code on the red light, error 90 and 93. So I'll start with the red light first on the error messages 90, 93. This generally is always coming from the generator, and it is a generator error code, nothing to do with the catheter. And most of the times this is an internal fault with the generator that needs to be replaced. But there is a test we can do to confirm that before contacting anybody to replace the generator, and that's the self-test mode. in that the generator, you plug it into the charger at an AC outlet. The battery symbol needs to be charging with the bolt on, and turn the generator on. Once that's on, hold the therapy button down and that will engage the self-test. That will be completed in 20 minutes, and obviously it will then pass or fail. If this fails, you need to replace the generator. There is no other troubleshooting we can do remotely, or you can do yourself to get rid of this error code. The generator won't work and it needs to be replaced. So with the amber light and the error code from 80, 81, 87, and 88, they're not referenced on the generator as to what is causing these codes. There can be any number of reasons. And much like anything in terms of IT, the first recommendation you always get is to turn the generator off and turn it back on again. And the reason we do that, whether that is your laptop, your telephone, a piece of CRM equipment, you're doing a pacemaker check, it always just resets everything internally within the IT equipment, and it may reset what the error code was. But from, again, my short-term experience and what I'm learning from my colleagues within the US and Europe is the majority of these are connector issues or air within the catheter. And primarily, I'm being told it is air in the catheter. So priority number one is turn off the generator, turn it back on, check your connections, and then purge and re-prep the balloon. And after that, from what I have seen, again, in my experience, that this resolves the majority of those error codes. If it does not, it is always down to the connector or the connector cable, and starting with replacing the catheter to get rid of the code, if not looking at having a spare connector cable in the cath lab to replace that. Okay, and that is my presentation. So thank you all very, very much for your time.
Thanks, Mark. I think it was a wonderful discussion. The presentations which you had given a great curtain raiser, and at the same time talking about the physiology of this particular innovative product, which has really made a lot of mark in India and helping patients to deliver great outcomes. What I would do now is I'll ask some of those questions which have already been made available to me. And these questions will be specifically to the entire panel, which is been here along with you, Mark. And I also have my colleague from Shockwave. We have Mr. Bhojraj also, and my senior most colleague, Mr. Parminder, also there. So I welcome them all. So we will have a first round of those, and then we'll take questions from all the entire the audience part. So let me ask you the first question to the esteemed panel of Mr. Sudhir Sette and all and Dr. Sakaria, every one of you. The first question that has come is that being such a specific and in a very innovative device, what is that IVL can do which Rota cannot do? That was a very nice one. So can anyone throw light on that, especially Mr. Sudhir, if you can do that for us and for the entire audience? Sir, you are on mute. Ritesh, can you make Mr. Sudhir unmute and allow him to speak? Yeah.
Can you hear me now?
Yeah, yes.
It's audible. Yeah. The question of the rotaplations, if we differentiate rota and IVL is totally different. Differentiation is there. In the rota is superficial calcification is there. The superficial calcification, nothing but next to the lumen of the artery. And the superficial calcifications, that is one it is suppose 180 degree in arc wise, then one should go ahead and do the rota. So question comes to the, what about those calcifications just near to the intima layer, just near to the media layer, and thickness is round about 0.5, arc is more than 180 degree or 360 degree. And the depth of the calcification was who will going to take care of it, because the rota will give the superficial calcification cut, agreed, but whatever the depth of the calcifications is a really question mark us. And secondly, the rota will give the vector forces will be in the opposite direction. So it is all depend upon the anatomy of the artery. Anatomy in terms of the wire, the rota wire is 0.009 inches, and that rota wire is fall on one of the surface. If the lesion is the opposite side of the lesion, suppose the rota wire falls in 9 o'clock directions, but the lesion is tighter lesion in 3 o'clock direction. So who will going to take care of it? That is a really question mark for us, because angioplasty nothing but a luminal expansion of the artery. We want a larger luminal gain at the right time. This generally happens to be you see in the circumflex artery. When circumflex artery, the acute bend is there. In acute bend, the wire falls on the one of the surface on the lateral side of the artery. Then we have a really the more concern about the opposite side of the artery, because the more fibrotic substance, more fibrotic tissues is found to be the osteal lesions. The cut is the one of the is difficulty is there. So if you want a more longitudinal cut, more depth you wanted to have it, we can easily achieve by the rotaplations, by the IVL thing. Because IVL will give you the 1:1 selection, but the rota maximum you get for 2 millimeter burr. But 2 millimeter artery, the artery size is very big in size, big in size in the diameter. Then the depth, the lesion purchase is not going to happen. The whatever the lumen gain we wanted to have it, we're not going to have. But the IVL is going to give you the more circumference wise cut, and the tissues and the segment and more fibrotic cut, and that also is going to get disturbed, going to get ruptures, and then we will get more larger luminal. That thing again, we can take the help of the NC balloon or the open NC balloon. We can create more luminal expansion, and nicely we can place the stent over there without doing the hindrance of the compromising the drug-eluting morphology, the stent morphologies and strain structures. Easily we can deliver, and whatever we wanted to achieve the result in terms of target vessel failure, in terms of the cardiac vessel cardiac death, in terms of the uh, stent stent thrombosis, the major three concerns what we are having it, what we are facing it till today, that we can achieve with the help of IVL.
Very nicely explained. I think the key learning here would be basically what IVL can do, what Rota cannot do, although these are complementary therapies, but at the same time, it is the impact of superficial. Very nicely explained. I would request the other panel, or Mark, if you want to add, you're one who has seen both sides of the table. I think you have seen Rotas of this world, and now you're seeing IVL. Anything which you think that Mr. Sudhir, we can add to it? I think he brings a lot of understanding of the subject, but at the same time, Mark, if you want to add something.
No, I completely agree. I think the only one point I'm quickly learning here from some of the physicians in Europe, from James Spratt and Colm Hanratty in particular, are the large vessel sizes and treating calcium certainly within left mains, of the role of Rota, that of the size of the burrs of not contacting the calcium can have very little effect, and that's something that is being brought to me from an education standpoint of some of these physicians to really hammer home that message of understanding the outcome if you're trying to achieve versus the technology you have within your lab, whether that is rotational atherectomy or IVL or laser or whatever it is understanding those therapies and what they're actually capable of before you pick one off the shelf, not just picking a technology that you're used to or you're familiar with.
Thank you, Mark.
Yeah, it's like,
Yeah, Miss, yeah, please, ma'am.
yeah, we also once experienced such a thing where it was a calcified RCA, where Rota was done with 1.25 mm burr, and we have seen that when we tried with 1.5 mm, 2 mm balloons, it was not expanding properly, and we were trying with some other gadgets, and finally we decided to use IVL, where the balloon could get across and it could expand, and it made nice crack in the calcium that we could see using IVAS. HD IVAS was showing. We don't have OCT, but IVAS was showing a very good image where we came to know that where a rota could not do the job, IVL could do. So in some cases, we may have to use both rota for the superficial calcium and deep calcium. IVL surely will take care of. So we had a nice result for that case.
Very nice, very great experience, Ms. Andu, and very nice to hear it out. I have another set of questions coming in, and I would like to ask the panel of Arnabda, Mr. Sakaria, Mr. Venugopal. Hospitals are asking, because if you see in India, the penetrations of imaging has not been about more than 3 to 4% or more than max to the 5%. Although imaging definitely helps us to basically diagnose things better and make your decisions better. But if it is not available, can IVL will work in ostial circumflex? How has been your experience? If there are an experience you can share, or maybe with your understanding, which also you can answer this to the entire group of the audience listening to it. Over to you, sir. Mr. Venugopal, Mr. Sakaria, or Mr. Arnab, any one of you can pick up, sir, and please answer it, sir.
So what you are asking about, you want to do a circ IVL?
Yeah, at the ostial level.
Yeah. So we can do the circ ostium. We did some cases. Okay. But we can do with a combination of work, something like a cutting balloon and the combination of OP and NC.
Okay. And this is more specific, Mr. Sakaria, in the light of the fact that if imagings are not available, do you think still this would be a great choice? That has been the question.
Because we can able to see the stent expansion, no? When we are doing that IVL or OPNC with that combination of work, in some cases it's a combination like a rotablator, cutting balloon, or IVL. If that more expansion if you need and lumen area we want to gain, we have to go with IVL. Even now, suppose we don't have imaging, we don't have IVAS, we don't have OCT. We can do the pre-balloon dilatation itself. We can see that bone inside of that balloon has been expanded or not. We can able to see in that. Even after that, even stenting. Even some cases, even post, I was telling that, even post, suppose we don't have IVL right now. We have to do the stenting, heavily calcium. We did. And after that, that lumen area where we are going to, we don't have OCT or IVAS, we did a stenting. After that, we can see that in the lumen area is gained. Even with an OP and NC. We did. We can do that without imaging also.
Very nice. Very nice. Any other cardiophysiologist like Arnab Da or Mr. Venugopal wants to add to the valuable contribution made by Mr. Sakaria?
Yeah, good evening. See,
sir, good evening, sir. I'm sorry. Sorry to interrupt. Yeah, Doctor, whoever Venugopal sir has said that it can be done in LCX, sir, with IVL. Yes, I absolutely agree that. But in case LED is compromised, then what can we do?
We have to go with the left main collet bifurcation stenting. Even some cases with the, it's audible?
Yeah, you're audible,
Then
sir.
absolutely.
You're audible, sir. Yes. Yes.
Yeah, absolutely. We require
that is the case, we have to go for a left main compromise or something. When you are doing that IVL in the circ ostium, if you are doing IVL, so no need of putting the wire into the LED. After that, if the vessel is going to compromise, then obviously we have to go for a bifurcation stenting. If we are going to compromise, we have to put the wire and left hand side, make it as a one branch is a side branch, and we have to address that.
Sir, not a LED. Not a LED.
He is telling about LED is going to compromise.
Talking about LED, sir. LED, yes. LED, yes. IVL is expanded, and the circ has been given a good result. and LED has been compromised, and you have put in a wire, then you are stenting that, then we need some IVL, no, sir, or some IVS or imaging, because again, after putting in a stent in LED, that circuit might be compromised again.
Okay.
The chances are there.
Okay. So what is your ideal treatment? See, we are talking about only
So
the
what do you say, sir?
sub-casting or bifurcation sending. No, if you are thinking about IPL for a LED and SIR, we can do the pulse is a variable, like a 40 pulse or something, you can go for a sarcasm, and 30 to 40 pulse, you can go for LED. Like you can split and do. What is the main motto? We want to do a stenting and lumen area, we have to gain it. Yes. So if that is the case, we can split into the LED and SIR, we can do IPL. We can, imaging is a secondary part. Imaging has come now. Some of the tier 2, tier 3 cities, they don't have IVS, they don't have OCT. How we are going to know? With the imaging, our with the contrast, with the cath lab injection, our regular angiogram. In that, we can come to know that.
Yes,
So we can split into the IVL into the LED part and off and different part off.
I am asking after compromising.
Sorry to disturb, Jack
No.
and the team. Jack, as you said, can you hear me?
Yeah, please.
Jack, as you said, you are the right point. What you explained to that. See, if it's the osteal calcium for the circumflex, the plan for IVL,
yes,
we have to go for the bifurcation sending, because you have to go for osteal. The emitter of the IVL catheter, it has been one is placed to left main.
Yes.
The other one is inside. So you never think about going for directly sending to the circ only. As you said, you are the right person to that. My advice to people to go for the circumflex circ, you go for the IVL, you plan for the left main sending. So you keep 2 wires into that and go for that. You don't have image. You take a IVL catheter place to the place and go for the send those image. So you can easily find out where is the lesion and where the IVL catheter is placed. Because IVL catheter has a 4 marker. It is a 2 emitters you can see nicely. So you don't think about going for only circplasty. The people who are working in Cath, please, I am recommending to go for the, as Zagreya said, is a valuable point, you go for the bifurcation stent. Or kissing method and put the circumflex, left main to circ and go for the bifurcation kissing balloon technique. I'm right, okay, Jack?
So it's correct. We can see the calcium score, especially if it's if you are using IVL, it'll be like a 360-degree calcium. If it's highly calcium, 360-degree only, we are going for IVL. Otherwise, we can go with a cutting balloon or angiosculpt, whatever. Only for the ostium scoring. See, only ostium stenting, it's going to be like a restenosis chance will be very, very high.
Yeah,
so
yes,
that is the case. We can go for a bifurcation, like you know.
Yes, there is a difference between angiosculpt or cutting balloon or rotablator, and compare with 3, the IVL is an entirely different technique. It is cracking that calcium.
IVL is going to crack. IVL is going to crack. It's going to give a multiple crack. But rotablator is going to share that calcium.
Yes, exactly.
It's going to be the share. It's not going to break the calcium. See, even earlier days, if you go only for 1.25, 1.5 rota, what we'll do after the pre-balloon dilation, stenting, and post-stenting, that stent was not, opposed to the wall. What we'll do? We'll go with a NC balloon. We'll go for higher atmosphere. Example, we put a 3 mm stent. It was a bone shot. It was not healing properly. We'll go with the OPNC to achieve the maximum pressure. Now, it has come a different way. We have a OPNC. And I was telling me earlier in the stage 1, if that ostium is offline indicated again, even post-stenting also, we can do the IVL to expand more.
One more doubt. Mark is on the line. Mr. Mark
is online.
Sir, there is one small doubt. Now there's a new things are coming, like after stenting, we can go for IVL. It is recommended or not
Mr. Mark,
after stenting.
So that is
stent is a-
outside of our IFU. I know many physicians do it and they do it successfully. I know from my Abbott days that they were looking at doing some work directly with Shockwave in their stents, in their R&D. Their R&D plant is here in Ireland. So there is a lot of work within and outside Shockwave within this area, but it is outside of our IFU. So it is not something that Shockwave as a company promote. And yeah, I guess that's my official line on that. I know there's a lot of work from not just Shockwave, but other companies within that area as well.
I'm sorry,
one enthusiastic question.
I'm sorry, Mark. We are, our hospital is recommending we are not going for after the sending. We are not recommending for the, it's a other situation. We have to do that. Otherwise, we are giving for pre-sending IVL is recommended. Am I right, Mark, sir?
So from the Shockwave IFU recommends Shockwave in de novo calcific lesions, not in stent calcific lesions. That is outside of our IFU.
One enthusiastic question.
Yes,
maybe it is a scientific error, I don't know. As our seniors have said that it is a bifurcation either versus rota or a shockwave. You are giving that traumatizing, isn't it? It is a calcification and you are traumatizing it. So once you are traumatizing it, that whatever the plaques or whatever the debris are shifting to LED because it is a bifurcation, left main bifurcation. So how can we avoid that?
So avoiding from to shifting to IV, LED.
LED.
The calcium is
absolutely yes. The calcium or debris you are doing in a bifurcation IVL or bifurcation rota. The debris obviously minute things might be shift because it is a bifurcation. So how can we avoid that? And I'm asking about the long standing, not as a picturizing or a presentation. Later on, that debris might be moved or might be fixed or might be stuck. So how can we say that it cannot be developed in LED osteo?
No, sir. Actually, you are thinking about a different way. There is a calcium in osteo circ. So it has been not shifted to, is never shifted to, or anything like like you're compressing to the LED side. It is not at all possible. When you break that with IVL catheter, it has been cracked completely. It will not shift. 100% sure it's not because of promoting. It is experience wise. I'm telling to you, it is never shift to that. So my recommendation, when the osteal thickness is more, you never think about going for NC balloon or OPN balloon because the NC balloon, OPN balloon never crack the calcium. It is the compress the calcium with the artery. If you go to more pressure, it be perforated. Bifurcation. If you bifurcation perforated, you will never save the patient. So you have to go for the IVL and crack the lesion. Then you keep the balloon in the LED. So open and send and both together. So it will not compress to the LED side. It is my advice, sir.
But if it is in a subintimal, then what you can see?
In the interest of having the conversation,
in the interest of time,
can I suggest all of you to put your questions on chat so that we have the expert panel and the right answer can be given on every question so that everybody can go through properly. Otherwise, it will be a little bit of
I completely agree.
Just requesting you, humble request to all of you.
I think there is a great enthusiasm in order to discuss, and I think you all have great points to share. That's why I can understand. So a thought from Arnab, and then we'll go to the next question.
Yeah, Mr. Ehsan, with reference to your question, first of all, when we see a sarcosteal lesion, we are not doing any image, then it is very difficult to choose whether we will use IVL or not, first of all, because how we decide whether we need to crack the calcium unless we see the calcium. See, in fluoroscopically, when you see any calcium, then we might think of using a rota, if at all our non-crossable balloon, because we have to go for intervention step by step, right? Like you park the wire, you use a balloon. When you are seeing that you don't have any IVAS, then what you have to do? You have to go step by step. You are using a balloon, maybe a NC balloon. When your NC balloon is not crossing, then you might have to take a rota. And after rota, if you are seeing that your luminal gain is not up to the mark, then you have to think retrospectively that yes, you have a deep calcium and it is not because of wire biasness, because circumflex lesion, as Mr. Sudhit said, for circumflex lesion, when you do a rota, your wire bias is very common. So you might not able to crack the calcium with rota, which you are expecting. So in that case only, you have to think for using a IVL retrospectively. It's not like the day one when we see a circumflex osteal lesion, we will start using IVL, because these are the therapy we have to use very scientifically. It's not that every lesion you have to use. And remember one thing, for using a IVL, when you are dilating IVL, you are spending a little time. So you are occluding the left vein also. So that's what my suggestion is, that you have to use IVL very judiciously. We have to use the IVL. Am I right, Mr. Mark? Am I audible, Mr. Mark?
Mr. Mark?
Sorry, I was on mute. Sorry. Yes, I would agree.
Yeah.
What do you think?
Mark, Arnab wants to basically seek your opinion. What he has given at this point of time. He was just trying to understand whether you are aligned to the thoughts what he was proposing.
Yeah. Yes. No, I agree.
Thank you. Thank you, Arnab, for your beautiful contribution. We have many questions, and I think we have a great panel to answer all of them. The next question comes up that there had been certain challenges which have been experienced by some of your colleagues here. They say that IVL wire sometimes gets stuck when coming from distal to proximal. Now, Mark, I think you and many esteemed panelists would be able to answer this question. What could be the probable reasons for this, if I have to enumerate few of them?
IVL wire is getting stuck. I didn't get you. What is that?
IVL wire gets stuck while they come on from because we generally work towards from distal to proximal. So when you try to bring distal to proximal, sometimes they have experienced the wire getting stuck. So what could be the possible reasons of this? That's what is the question here.
I would imagine that's the balloon getting stuck more than the wire getting stuck.
Balloon is going to start on the wire. I had experience on this twice, not once or twice, because if you use a hydrophilic wire, that balloon going to be stuck. Absolutely, 110%. Why? Because you are generating a heat there, so that the balloon lumen, the internal lumen, is stuck into the hydrophilic wire. If you are using a floppy wire or a Teflon coated wire, the balloon is not going to stuck. It is going to come. Absolutely sure.
Any thoughts on this? Yeah, Mr. Sudhir wants to say something. Yeah, Mr. Sudhir?
I will not going to name any company. One of the MNC company, what they basically have a wire shielding. The wire get connected over there, one spot. That spot is called the junction of this wire. So we have faced many times at that junction, basically even not using the IVL, even the plain balloon gets stuck over the period of somehow somewhere get. We are reported also. That junction may be the cause of this thing. And secondly, the hydrophilic wire, whenever you we have to lubricate the wire while introducing it. Similarly, whenever you're putting the IVL balloon also, you on the shaft also, you get it lubricate very well. Has to be get lubricated. And secondly, the wire always we go distal to proximal. So lesion preparation is a must, I would say. Lesion preparations means what? Whenever you want to use IVL balloon, you prepare the lesion very well, first of all. Unless until you prepare it, then only as such scenario will not going to arise. So you must prepare the lesion, make the adequate luminal expansion of whichever balloon you're taking it, just adequately opened it. Secondly, you start with the opening of 1.5, start with the 1.5, then start with the 2 millimeter balloon. So the artery size is 4 millimeter, go maximum 2.5 millimeter balloon, just open luminal expansion of that balloon nicely. Then you, once the bed is created nicely, then we can, we can have as such consensus about the procedures, what we having it here now. Hydrophilic wire, one of the concern, agreed, but lubricity we have to maintain while introducing it. While you introducing the wire, PTCA wire, hydrophilic, we have to make the wire more lubricious, even though stainless steel core also, sometime we have to make it.
So
I would like to add one point.
Hydrophilic and hydrophobic, but we come across with so many cases with even hydrophilic wire.
Yeah.
But we are not coming across with any struck. Like you said, we have to do a bed preparation first.
Correct.
The lumen 1:1,
Correct.
because IVL balloon is little bulky.
Correct.
We can't take like a regular semi-compliant or non-compliant to track that vessel.
Correct.
So the particular the way of interest, which is the blood vessel.
Correct.
It's a middle lattice of the. We have to go over it's 1:1. Do a good balloon dilatation. Then you can go over IVL and break the calcium. Then only that we can achieve the stent expansion and post balloon dilation. The result will be
if we talking about the crossing profile of the conventional balloon,
yes,
the
sir.
crossing balloon about this balloon is totally different. Is double than the conventional balloon. It's 0.021. Now he's a 0.042, and as the sizes increases, it's become 0.044, goes to 0.044. So that being considering the profile of the balloon, one should go ahead with the lesion preparations while before you introduce the IVL catheter.
I would like to add one more point. See, like when you are using a rota, so our therapy is from proximal to distal, not from the distal to proximal. Okay. Right, Mr. Sudhir?
Yeah.
Yeah, the same way, what happens, sometimes people are taking IVL, and what you said, that is correct, that you have to do a bed preparation. Why? Because if you are doing a rota not from proximal to distal, instead of proximal, you are started from distal. See, often we see that our rota bar gets stuck, because what happens that we have come across the entire calcific segment and we are starting rota, we are pulling the rota. The same way, if you are taking without proper bed preparation, if you are taking a IVL, you might gone across the lesion.
Correctly said.
And while pulling, it is getting stuck. So our therapy should start from proximal to distal in case of calcified lesion. Right. So for IV, when you are taking IVL, you may not able to do from proximal to distal. There you have to do a proper bed preparation. So there should be enough lumen to pass your balloon through and through. Then this experience may not happen. What we have seen in our experience.
Sir, sorry to disturb, sir. I'll interrupt. I have a doubt that my seniors has explained very well. I want to point out that if you prepare a bed very well, either it is a floppy wire or either it is a hydrophilic wire, or as last our Sheehan sir said that okay, you are dilating from the proximal to distal or distal to the proximal. But once you dilate from proximal to distal, because the balloon is very bulky, once you dilated that proximally, it may not cross to the distal.
That is why you need to do a proper bed preparation.
Yeah, no, I'm telling that after dilating with, suppose you are taking a 2.5 balloon, NC balloon, you are preparing with NC or OPN balloon with a 2.5 or 2. After you are taking that Shockwave balloon of 2.5 or 3, then which balloon we have to dilate? That you please guide us.
See, suppose your vessel size is 3 millimeter and you are taking an IVL of 3 millimeter, because IVL you have to take 1:1. So then at least 2 to 2.5 millimeter balloon you have to use, preferably with the NC balloon. Prepare the bed nicely, then you take the IVL.
I think that is the suggested point. Very nicely answered. Respecting time, we have a lot of questions coming in the chat box, and I'll have the first question, which is from Mr. Shivdyal. Sir has asked, is buddy wire safe during shockwave? Anybody, Mark or Mr. Gill or Ms. Indu, anyone, Mr. Venugopal, anyone who can pick up this question and do answer if need be? Yeah, Mr. Venugopal.
Can use buddy wire. It's not a problem. Can use buddy wire.
Buddy wire can be used. Yeah, Mr. Venugopal, please.
Buddy wire we have not used, but we use in side branch protection wire. We did superficial calciums used in IVL, but not used for buddy wire. Entire vessel we are not. So side branch protection we use into LED and diagonal, but same thing we did IVL, but you can use.
Okay. There is another question from Mr. Sivdal. Is a dilution of contrast has any role in emitting the waves, or it is for inflation and deflation? Mark, would you like to take this question? I think it's more physiology. Mark? Is Mark there?
No, sir. Sir, he's not there.
Okay.
But I can say, sir.
Yeah, please.
It is absolutely implicable, because if you more dilatation or more viscous, that balloon dilatation or deflation will be impact. It should not, because the deflation will be very slow happens, because it is a very bulky balloon. Once upon a time, I have been done this, my mistake, and I have faced a nightmare. So the balloon was not deflated, because we are generating a heat in that it is a sodium basically. So once it get heat, it become hard. Once become hard, that balloon dilatation and our deflation device will not be act on that one.
Very nice, very nice. I think Mr. Mark has left us because he has another call in the evening. That is why he has left us for the evening. It doesn't matter, but I have, I think we have equally, the Indian experts are equally no less in terms of understanding, and I think they can add a lot of value to it. There is another question from Mr. Parag Vavsar. If your artery is tortuous, will IVL cross? Anyone, Mr. Sudhir, Indu ma'am, or anyone can take Mr. Avatar, one of the anyone.
Yeah, even in, shall I?
Yeah, okay.
Yeah, I think even if it's a tortuous vessel, we can take that IVL. One, we can use buddy wire, or even with the guide extension catheter, we can get across the lesion. We can try in tortuous lesion, and the crossing profile is very low, 2.4 or something. So it can be tried with guide extension catheter or even with the buddy support. These two conditions, I think tortuous vessel also IVL balloon can get across.
Very nice.
I can add.
Guideliner will be in supporting review. Helpful.
Can be used. Can I say?
Please,
but only one thing, Buddha, is a very, very important thing in the tortuous vessel. It might be concertina. If a concertina is not there, the angle is good, can be used. Or can be used with the guideliner and with the buddy wire. And after when the cross, you can pull the buddy wire. If the concertina is not there.
One more suggestion, sir.
Yeah, please, sir.
They can actually, guideline is absolutely, I agree. It's a fantastic option. After that, if it is not crossing, if it is the entire vessel is calcified, we can dilute partially and slowly inflate and give the pulses, and you can cross. If it is entire vessel is calcified, if it is only discrete segment, then guideline is absolutely, there is no other.
Yeah, Mr. Sudhir wanted to add some point, I believe. Yeah, Mr. Sudhir, please go ahead. Sir, you are on mute, sir. You're on mute, Mr. Sudhir.
Very interesting thing. Always we are facing the tortuous anatomy of any vessels, and that also calcified, tortuous distal vessel. And in those scenario, the guiding catheter support is must. Suppose the artery is very tortuous, the crossability one of the question mark for us. So how do you go? How do you one should go about this crossability of this thing? So crossability in terms of the delivery of the stand. Of the deliver the stand, we're going to compromise the stent truss, compromise the drug elutions, and compromising the stent thrombosis, and ideal we'll end up with many complications as such. So one should go ahead with the uh, guide support catheter. Support catheter, I would say. I will not specify any company name. There are 3 more companies are there. Guide support catheters, you can use it. So support catheter one that one should use it for such a scenario. So there are various techniques how to cross over this IVL catheter. So one technique is called torpedo technique. Second technique is called the tracking technique. Third technique is called the anchor balloon technique. So suppose we're dilated and stent is not going and we want to dilate with the IVL balloon. So what one should do it, take the balloon, take if you want to advance this support catheter, So support catheter, you inflate the balloon at the tip of this support catheter. IVL balloon, you can inflate it lightly 1 or 2 atmospheric pressures. While deflating, push the guide liner or push the support catheter further inside. So this technique, we can use it. Second technique is that as much as guide liner, as much as the balloon is going, IVL balloon is going, go up to there. Again, you inflate the balloon 1 or 2 atmospheric balloon. Again, you cross over it. It's called the anchor balloon. And third is the inchworm technique. So serial, you catch the lesion, again is advance the further. Second, at the site of the, suppose at the site, if you want to go and we want to drag this guide liner at the site of the stenosis, again you inflate the balloon at 1 or 2 atmosphere, again you advance further it. Once it is got advanced, then take out the guide liner catheter out, and you can prepare the bed very nice luminal expansion. We can prepare the bed with the sufficient amount of energy we can deliver at the site of the lesion. This technique is ideally been used, and many centers are using it. I have read today one of the articles. People are using with the support catheters, and successfully we can deliver the stent as such technique. Thank you, sir.
Very nice. So nice.
Sir, one question, sir.
Yeah.
Sir, whether if it's traumatized, then what you have to say? Some side protection we have to.
One minute. I forgot to tell you. It's very important, guys, and you have to be write it down in your book or something. When you're crossing the guide liner distally, very important. Listen to me. Whenever you're crossing the guide liner distally, always see the pressure tracing. Always see the pressure tracing. I'm emphasizing you. Why? Because you may be in the false lumen. You are extended the luminal expansion and you inject in that thing, then dissection. Whole thing will mess up. Whenever getting a damp pressures while advance the guide liner, never ever inject. Again, you withdraw whenever getting a pressure, nice pressure tracing. There you inject and just see. That is a summarize of this entire event, the entire session of this one.
Sir, but guide liner doesn't have a pressure connection, no, sir, because it directly goes on the wire.
But you see the pressure tracing on this thing. The pressure tracing will come on this scale. Not I'm talking about guide liner, it coming through all segment, because guide liner, there's one more catheter, that is the guide liner plus external catheter, we'll get the pressure over there always. Even the CTO cases also, whenever you cross the micro catheter, always see the pressure tracing over there. Always see pressure tracing, whatever you're getting it over this thing.
Thank you, sir. Thank you very much.
Thank you. Respecting time, a very nice discussion. I think it's so interesting to hear thoughts from different people. The next question is, is the question on underexpanded and ISR cases. What do you see the role, although it is not a part of IFU, it is not the line of Shockwave, but this is a question which has come from various audience, that what would be the role of IVL? So anyone of you, this team panel, can take this question and help us to respond, which may not be truly the Shockwave line, but yes, your experience are equally important.
I think we can use IVL in under dilated or under expanded stent, as we had one case with in our lab where we got under expanded stent and we use IVL for this, and post IVL we got very good lumen, and yes, this is offline indication, but we can use.
Yeah. Anyone, if you want to add to what sir said?
My understanding. Hello.
Yeah.
Yeah. To my understanding, see, mostly the ISR comes with fibrotic lesion, right? So until unless we face calcium, we very less chance we face calcium on that. But preferably OPN is gives better result, because if two things, one is neo-intimal hyperplasia and another one is the malapposition. If it is a malapposition, then
under expanded stent in any lab, that must be because of fibrotic lesion or maybe some calcium which was not imaged properly before doing a PTCA there. So if there is any fibrotic lesion, then you can expand it with using a non-compliant balloon or so. But if you are if there is calcium, then that stent can be expanded by your IVL, by using IVL there. That will not properly deployed without using IVL. You can achieve some lumen by using high pressure balloons like
OPNC or NC?
Apollo or OPNC. But for a calcified nodule, you have to have IVL there.
But
because I have
prefer,
got experience with this.
For ISR, sir, actually I prefer some imaging, because we don't know what is it. It is a calcium or it is a fibrotic or the
absolutely, absolutely. Until unless we do image, we can't make it a call.
Many times, as we all have experience in our labs, that imaging is not possible there. Because of some financial constraint or maybe the time constraint, because imaging took some time to get it done. But for under expanded stent, we can use IVL if there is calcium, because if it is due to calcium nodule or if it is not expanded with high pressure balloon also.
Absolutely agree, sir. I absolutely agree. IVL is also not, I'm not telling that it's not completely not an option, but if imaging will help you.
Imaging will help you, definitely imaging will help you, but many times that calcium is not really visualized with your Cath lab imaging. But
yeah, that's what I'm telling. That's what. Yeah, I agree. That's what Cath lab imaging, fluoroscopy imaging is not. It will not at all helping you in calcium, but only stent is only visible, and you are doing IVL. We don't know whether that if you have a past history, if it is a 2.5 stent, and
it's not necessary. I just want to add one more point, and it is not necessary that every lab should have that imaging there. Many times,
I agree, sir. Most of the labs will not the imaging, and what I'm telling you that my point is that suppose if doesn't have a past history, because see the patient come with a ISR of 10 years old, and you don't have any documentation. The stent is, we don't know which size of stent and what IVL balloon you will use. Minimum starting after 2.5. I will
recommend Rota Tripsy for that restored stent. First do Rota, then a high pressure balloon, and if it doesn't expand it, then you should use IVL in that under expanded stand or the small stand.
Which size of rota you will suggest, sir?
If it's a 2.5, can go for 1.25.
No, I will recommend to use in that case. I will if it is 2.5, then I will use 1.5 millimeter burr.
Sir,
for
we
that.
don't know the stent size. What they implanted initially 10 years back.
That is
But
okay.
when
But
you are doing that angio, when you are doing that angio, you can do the QC, no? You can do that, basic calibration of the blood vessel.
Vessel diameter.
Vessel diameter you can able to see, no?
True, sir. Yeah, true. I agree. Completely agree.
Even eyeballing can give you an idea of that what the size of the vessel.
True. But while doing that, if that any studs are got distracted, then
That's why I ask you to just go with rotatripsy, just pass a wire into that stand, do the rota. If you're once you pass the rota, then go with high pressure balloon, and still if the stand is under expand, then you can use IVL.
maybe I'm wrong. If I do that NC balloon dilatation, if that lesion is whatever the lesion or plaque has been cleared, then what can we do?
Pardon?
I think that will be well good.
I didn't get you. Can you repeat it again, please?
No, sir. If that ISR, the lesion, if you dilate with the NC balloon, that NC balloon cleared that plaque, then I think we can go ahead with the stenting.
Exactly.
Otherwise,
So
go for
judicially
only TEP and come out. Otherwise, do only if you can achieve at the lumen area, go only for drug-eluting balloon. No need of putting one more stent.
Exactly. I do agree with you.
I agree. I do agree, sir. I do agree.
Just do rotablation, go with higher pressure.
My scenario is at 10 years old stent. Then the drug-eluting balloon will be suggested.
That is the ideal one.
In fact, just to respect time, I think what I'll do is, in fact, I'll add one point and maybe take the another, because I have list of questions and we are running short of time. I think such an interesting discussion. Just to give you a brief, that there had been a registry being run called Dragon, which is trying to understand the role of IVL. Although it is not a part of IUFU, but results have been quite encouraging, as most of you had alluded to, that this has been this can be one of the choice apart from various other therapies available. Now, my next question is from Mr. Manoj Sharma. He says, it has been observed that balloon ruptures at the time of IVL shockwave. Why it happens? Can anyone explain and help me to avoid this? This is a very interesting, I think, very practical question, in fact, and anybody who has experience and had a very less incidence of balloon ruptures, I think it's more about balloon preparation, which makes this one can avoid. So I think coming from some of you who is used in many cases would be a great answer. Yeah, Indu ma'am, you wanted to speak something on?
Yeah, I also experienced in initial days, we had 2 cases of the IVL balloon rupture, where we were in a panic situation, and luckily we could tackle that situation. And as a conclusion, we came to a conclusion was that it might be due to the balloon preparation, where there was an air bubble which can cause damage in the balloon during the next cycle. That might be the reason. We also were not sure, 100% sure about the reason. So we had 2 cases where it ruptured and it perforated the vessel, and anyway we could stent it, and we expanded it properly with OPN balloon, OPN high pressure balloon. So we also were not sure about the reason, but we are expecting that the balloon preparation itself made the problem. The balloon bubble might have created the issue.
In
Can
fact,
you join, sir?
spark
It could be a calcium spar in the particular angle can be for the balloon while passing that lesion.
One more, sir, if you don't mind, can I join?
Please.
Yes, sir. Actually, I have done the peripheral balloon, peripheral IVL also, and as well as cardiac IVL also. What I face is that sometimes the preparation, while doing the preparation, the aggressive preparations of that balloon, we will do that removing of the air, the bubbles, and by mistake, sometimes that whatever the electrodes, there are the two wire specters will be there, which our four spots will be there, that eliminators, terminators will be there, where that wires get attached, then that balloon get burst. The chances are there because it is a positive negative. There will be a chances of a connection. If the preparation is aggressively done and that get bent, the two wires get joined, and that electrodes can happen.
True. It is all on preparations. I think that's very important. And this was very nicely explained. Yeah, Parminder sir, if you can add on to it. Yeah, please go ahead. You are on mute, Parminder sir.
Yeah. So this is a great question, actually, on the IPL balloon bursting. Now, what we need to understand is that there are actually kind of, when you talk about the burst, okay, it can be because of three reasons. One is, as somebody said, that, it's a calcified nodule with a spicule. Because if in case you have an eruptive nodule, okay, nodules also kind of, can be smooth nodules, or it can be eruptive jagged kind of nodules. So if in case an eruptive nodule is there, which means that actually it is going to be, kind of, protruding like a spicule, then any balloon will burst. So that's one of the reasons why any balloon would burst, including IBL. That's one. Secondly, as also somebody said that, the emitters are hot, right? So am I audible to all? Because
yeah,
I'm getting on
yes,
I'm getting on my screen unmute to start speaking, so that's why. So so the second reason which is there is now you got to differentiate between a burn. I repeat this: a burn, BURN, and a burst. Okay. So now let's distinguish between the two. So now when you actually kind of given the pulses after inflation of the balloon, you've given the pulses, and now the 10 pulses are over. Okay, then your therapy button will turn orange. I'm sure that all of you would have observed this, right? So when the therapy button turns orange, and if in case you deflate it immediately, then in that case, those emitters which are hot, okay, they will actually burn the balloon. They will burn the balloon, and what appears to you in the next cycle will be a burst, which means that you will perceive that as a rupture. But actually, what has happened over here is that those emitters have not been allowed to cool. So what is actually that you need to do is that when your orange button of the therapy is on, okay, do not deflate the balloon immediately. Allow some time so that the orange button which is there, this color which is there, turns to green again. The reason is this, that when you're allowing this time, the emitters are now cooling off, okay? And now when you're deflating after that orange to green transition has taken place, then what is happening is that the emitters are cool, and the plastic which is there of the balloon is not going to kind of scald or kind of burn the the plastic. The emitters are not going to be hot at that time. So this is a little precaution if you take. That one, that even the calcified nodule, you can probably kind of have a rupture because of a spicule. That's one. So differentiate between a nodule and a spicule also, right? Second is, if in case you are having to safeguard your balloon, then in that case, make sure that, after you've given the pulses and the orange button has come in, on the therapy, then in that case, allow it to go to green, so that, you allow the balloon to, the emitters to cool down, and then deflate the balloon. Don't deflate the balloon immediately. That's one of the most important precautions that you can take in order to save your balloon for all the cycles that you have. And of course, the third thing which is there is pulse only at 4 atmospheres, because there's no point in going at 6 atmospheres, because this is, as everybody has agreed upon this, This is not a balloon which kind of, is there to create pressure. It is only to create contact. And once the contact is obtained, then of course, IVL does the job through acoustic waves. That's what I have to say. Thanks.
Thank you. Thank you very much. I think we have a lot of questions, but we have paucity of time. I would say, with respecting time, with people who have joined for such a long time, the last question, and then we can wrap the evening. Can you please highlight, Mr. Ravindra Pandurang has asked it, can you please highlight on use of IVL in calcified bifurcation? Although we will answer it more from the company standpoint, but if anyone who has experienced and who can talk about it, please feel free to throw some light on that. Can this IVL can be used in this indicator? Mr. Sudhir or Mr. Venugopal, anyone who have used in this indication can share their views.
In bifurcation stenting, suppose LED austere and circumflex austere is there. Always try to go with the protect first major artery. LED should protect first, then start with the circumflex austere, and you can give the initial 30, 40 cycles. Then again you withdraw the balloon IVL, go to the LED. Again there 30, 40 cycles, 4 bursts and 4 cycle we can give it over there, and watch for the result. If the result is okay, then we can come out and we can do the bifurcation stenting as such thing.
Right. In fact, thank you very much, Mr. Shetty. In fact, there are some datas also. In fact, in past, there had been an experience where your colleagues and professional colleagues of past at various centers have used IVL in bifurcation, and that's the beauty of this therapy. And that what makes me to bring to a very important summation of what does IVL stand for. If you look into this therapy, IVL today stand for something called a very safe treatment. In fact, today,
sorry to interrupt, sir,
can be used in in such an indication where perhaps in past other therapies like Rota and others were still could have been used, but with a lot of difficulties. That is why it is called a very predictively safe therapy. In fact, it is also called, IVL is called as a distinctively intuitive therapy. And what we mean to say when we want to say that it is such a commonsensical kind of device which does not requires any basically a learning curve, which is just a mere balloon. There's no knowledge curve here which requires to be basically understood in order to make this therapy. It is such an easy therapy, and that is why today this therapy does not requires many a times lot of assistance from people, because in past you have seen that when people have to use Rota or people have to do imaging, some people running from the company would run and make which support you. But I believe you being such a great cardiac physiologist, perhaps you do not require somebody like us to come and because that's the beauty of this therapy. This saves a lot of time. This makes your life easy. It's basically any time on demand you can have and use it, and you will be using it with the same ease which perhaps anyone from people would have assisted you. So that's the beauty of being distinctly intuitive therapy, and then consistently effective irrespective of any sort of lesion, whether it was concentric, eccentric, or in nodular lesion. In fact, today we have sufficient and volume of evidences to suggest that today IVL has been found to be effective in all type of lesions, whether it was a concentric one, eccentric, and a lot of discussions now is happening on the nodular lesion. In nodular lesion, you may not get the kind of results what you would have got in concentric lesion, but you get enough to get a lumen gain. And that's what is your objective many a time. With any of these existing therapies, sometimes it is not possible to get a similar kind of results. And what is very interesting today that IVL has become a darling of choice, especially when it comes to treatment, especially in women, because in past it has been studied that in women various other atherectomy device, especially rotablators, has been found not to be as safe as in men. But whereas in fact with IVL, with the disrupt cat data, pool data clearly suggests that it is one of the safest therapy as far as in women patients when PCI is to be considered. So what the whole idea of this platform was to also suggest you that whenever you based on this volume of evidence, whenever you have to give your opinion about using, perhaps you can give, because today this is the only therapy which has evidence in female patient, and you'll be very happy to know that there has been one of largest study called Empower Cat is getting commissioned, where the female patient will be part, which no other therapies in the past has done or has been established. So that has been the kind of therapy choice, and we will be expanding in many more things. I think what I would request that in future keep on giving us a lot of more wisdoms, your thoughts, your suggestions, to see that IVL becomes a real choice. Sir, our fight today, the whole objective of this therapy is to see that how do we fight calcium today? How do you make patients better? We are not fighting with any therapy. We are fighting with calcium, which is a culprit for all of you and all your patients. And I can tell you that today, with IVL being in your hand, today there has been a complete democratization of therapy. What I mean to say that there are no more a large center and small center. Today, with the presence of IVL, this is such a handy device which can treat all kind of patients. Anyone can do it, and with a very pristine outcomes and with a pristine results. That had been the message of the evening, and we will continue to interact again on this beautiful.
Sorry to interrupt.
We got, thank you very much, and we would like I think someone wanted to add. Mr. Sudhir, you wanted to add something?
No, sir, myself.
Yeah, please.
Actually, someone has asked that bifurcation stenting for the left main and suck.
Yeah.
Actually, my 2 years past, I have done one case. My experience, I will tell you that I have done IVL, distal left main to LAD, as well as our Venugopal sir has said that 3 cycles and 4 cycles. Yes, I agree with that. After 2 cycles and 3 cycles in LAD as well as circ osteals, we have stented only to left main to LAD, and we have done the pot to circ through the stent.
Thank you, sir.
And that study has been already presented somewhere. I will speak with my colleagues, and I will present somewhere.
Sir, sorry for my ignorance, sir. I am not able to recognize you because your name was also not there, yes. Sir. You had made such a wonderful contribution, sir. I think your colleagues might be knowing, but just for sorry for my ignorance, if you can recognize yourself, sir.
My name is Satya, sir. I am from Goa, Manipal.
Oh, okay. So nice, sir. So nice.
Raja, sir.
Yes.
I'm Sakarya here. One more, my small question.
Yeah.
Anyone has done example for the left main bifurcation? Example, left main I done. I'm telling about ostium LAD and ostium sir. Okay. Example. We can take a little bigger guiding. We can park. I mean, we can do the bed pressure of the bed. I mean, LAD and sir will do the pre-balloon dilatation well, and after that, anyone done is a 2 IBL. Simultaneously, we take one, park it to the example LAD distal or mid LAD or something. You can park it, and we can do a circ IBL, and after that we can change over to the immediately to the pull out that other IBL and connect it, something like that. Anyone done any case study, something like that? We can do a example 3M.
So far we didn't done, sir.
We can park it the distal and do that.
Yeah, sir, we can. I think so, but it is a little bit risky. Life of the patient.
Anyone from the company side, they assisted something like that left main, I mean LAD ostium and the circ ostium. They've taken the 2 IBL, park into the 1 IBL to the distal, other IBL they can do, and simultaneously immediately we can pull that other IBL into the LAD ostium. We can do something.
Parminder sir wanted to
So,
add.
Sakaria sir, basically, the cost definitely is always a constraint, in terms of even one IVL. Doing two IVL definitely is a little kind of distant for, the operator to look at. But what we have done is that we have done in left main, for instance, we have done distal, we have done eccentric calcification in left main stem itself. We have also done, bifurcation at the LCX as well as also the LAD with the single IVL. And I think Sunil was pointing out towards this, that, the left system, normally you would find that the RVDs which are there, reference vessel diameters which are there, are more or less going to be kind of, the same. So if in case you're going to have, one IVL to maybe, about whatever time that it takes to debulk maybe the left system, whether it's an LAD or LCX, okay, you can do that either ways and then go on to the next artery without any problem. Having said that, in the left main, I would just like to point out, I'm sure quite a few of you know it, but since in the left main, you can have something what we call as a stage pulsing, which means that if in case the patient is hemodynamically not very stable and you wouldn't like to have more ischemic time, then in that case, you can actually give only about 5 pulses or even less if you would like to, because the trigger is in the operator's hand. So the moment he pulls the pressure off the thumb, that the machine is going to stop, the pulses are going to stop. But normally what we suggest is that if in case the patient is not very stable and you still want to kind of stage, you can do 5 pulses, which means that you place your balloon, okay, in the left main, add 4 atmospheres, and then later on you can probably kind of, deflate it, as I said. And then of course, up 5, so 80 will go to 75 and then deflate it. And then again, when you start again, it is going to be 74 to 70. So which means, you're actually going to have the 5 pulses cycle every time, and you're not going to lose on any pulses in any manner, So this can be done very, very efficiently in left main, as well as in the LCX, as well as in the LAD bifurcation. Yes.
I think Parminder sir has an eyewitness, sir, that my left main case has been, he is eyewitness, I think so.
Yeah, that's right, Satya sir. I think we've done a beautiful case at that time.
Yes,
and,
yes.
Thank you, sir. Thank you to all. I think we had a great time. I think you'll be happy to know that 225 or 28 people attended this. I think very few of this program of this nature would have been attended by. And I really, on behalf of Shockwave, Mr. Bhojraj and Translumina, we together as my entire team, Mr. Parminder and Ritesh, we are so thankful to you to be part of this wonderful program and really contributing it and making it so rich. I'm sorry that we could not, because of paucity of time, we could not take all questions. But what I may request is that Ritesh would be taking this question, and perhaps we can answer it personally, one-on-one, or through our medical department, and that would be our option next time. So thank you very much. I take this opportunity.
Sanjay, I would leave them with one question, and probably if in case they can give us their inputs. I'm not going to answer that right now, but how is it that you will use IVL across a bend? So for instance, if you have a bend, then in that case, how would you use IVL? Would you put IVL at the bend? Would you do proximal, or you would go distal? So this is a question for thought, because this can save you your balloon if in case you choose the right strategy.
Thank you, sir.
So just think it over and give us your suggestions. You can kind of, if you WhatsApp to any one of us, it will be a great kind of, learning for all of us. And of course, we will answer the question, whenever you'd like to.
Thank you, and good night to all of you.
Thank you very much.
Thank you. Thank you so much, team.
Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you.